Thank you, Sachwat. So we shall be talking about now about the post-refractive situations where you are doing a cataract surgery. So this is a 30-year-old gentleman who actually was a neurology resident who came to us complaining of a little bit of a blur in his vision and especially the night glare while driving. He had undergone LASIK about 6 years ago and had a very good post-op results. Vision was 20/20 immediately after LASIK. He had undergone barrage laser in both eyes, which is not related to this particular situation. So his vision at that point was 20/25 uncorrected, and this was his refractive error about plus 0.75 spherical and a minus 0.5 cylinder, effectively about a spherical equivalent of 0.25. He had a very early nuclear cataract, and we did not feel fit that this need a cataract surgery at this point of time. However, the situation worsens. His vision dropped to 20/60, and he had a significant nuclear cataract over the next 6 months, 8 months, and then we decided to do a cataract surgery for him. And these were his scans, and that is oculizer. You can see the keratometry is as flat as 37 in almost the both eyes. We routinely use the ASCRS IOL online calculator for these kind of a situation. So that is what we use. As you can see, this has input. You can, if you have input for a pre-LASIK data you can enter that. If you don't have, does not really matter. You can have the post-LASIK data can be entered. And in this situation, we entered what was the current keratometry, which we took from the pentacam or the oculizer, and then the anterior chamber depth and the axial length. And then this is what we got approximately. So average was about 20, and if you had used SRK2, then what we were getting was about 16 diopter. So there is a difference of about 4 diopters here. So if you ignore this, or if you do not get to know that the patient had a LASIK done, then probably you would be getting a hyperopia of about 2 to 3 diopters here. So this particular patient after 3 months had a vision, the refractive error of about just about minus 0.5 cylinder with the vision correcting to 20/20. Now we are planning for the other eye cataract surgery also. So why is this difference in what we get in the routine IOL calculator and calculations versus the post-cataract, post-refractive surgery surprises? That why do we get that? So if you are following the patient who had gone myopic corrections by LASIK or PRK, you probably would be getting unexpected hyperopic surprises after cataract surgery. If the patient has gone hyperopic corrections for LASIK and or PRK, then probably you will be getting myopic surprises. We do not have much experience of hyperopic correction because the numbers are very, very few. So for IOL power determination, as has been discussed earlier, you basically depend on the axial length, the anterior chamber depth, and the corneal power. Axial length generally would not change after your LASIK surgery, LASIK or PRK surgery. There's hardly much difference in pre and post refractive surgery in the anterior chamber depth. However, the corneal power does change, and that is what makes a significant changes in the IOL power calculation. So if you are undergoing the RK, the whole cornea would flatten. However, if it is a LASIK, it's the anterior surface of the cornea which gets flattened. And in the hyperopic LASIK, it's basically the curvature or the it steepens. So cornea, we are basically making an assumption when in the routine biometry that the cornea is a true spherical surface and the posterior radius of curvature is 1.2 millimeters steeper than the anterior radius, and the power of the paracentral 3 to 4 millimeters is nearly the same as that of the central cornea. However, this is no longer true once the patient has undergone the refractive surgery. Also, there is an issue of ELP, what again has been described earlier. So the effective lens position, which the IOL calculators basically presumes, is much different than what actually is in this particular situation, and that also plays a role that you get a different IOL power than what actually should be. So there are many calculators and methods which has been described to measure the IOL power calculations after refractive surgery. However, most of these are theoretical. If you are a resident, yes, you need to know about all these, that where you should need pre-refractive surgery data, topography, or there is a method where you do a over refraction by after placing a contact lens. There are some nomogram based adjustments which can be done or directly using the posterior curvature. However, practically speaking, most of the time in our institute, most of us are using this online calculators, and what we use is the ascrs.org online calculator which is available. It gives you a different calculator for post-LASIK and PRK eyes versus a post-RK eyes. So what you have to understand is, even here there can be some variation, and you do not get a single power or a IOL power every time. You would get a variation. It makes sense to use 2 or 3 methods and then maybe take whatever is the higher of the 2 values. The IOL formulas which are recommended in these situations are Hoffer, Holiday, SRK2 or Hague's, and many a times now these days we are preferring the Barrett's universal formula. This is another case which this is a 49-year-old housewife who had undergone RK way back about 30 years ago, and she presented with cataract in both eyes with the vision of 20/100, which was improving to 20/50 with pinhole. You can obviously see the RK marks on the cornea. So this was her oculizer. If you do a routine A scan, this is what you would see. Your SRKT gives you about 16, 15.5, and the SRKT is giving you about 17.0. But when we use the IOL calculator on the online calculator, what we got was a 18.93 to 19.69, and what we used was 19.5. And this is her post-op refraction after 1 month. She ended up with a cylinder of 2 at 90 with a corrected vision of 20/20. So to conclude, IOL power calculation is simplified due to the online calculators. However, you still need to expect post-op emmetropia, and it's very, very important that you should discuss this factor, this possibility with the patient preoperatively, that you might end up with some kind of a refractive error after the surgery. You cannot exactly always be within 1 diopter all the time. Thank you for your patient listening.
Thank you, Dr. Mukesh. So are there any questions regarding post-refractive calculation from the house? I think one of the things is that it's really complicated if you want to get into the nitty-gritties of it, but the calculators online make it easy. So probably it's more important to be aware that the patient has had a refractive surgery, which is getting more and more difficult by the day. So, a flatter cornea, 37, 38, you have to probably proactively ask the patient.
So some of the patient, like this neurology resident, had the papers with him and we could get the pre-op data, but otherwise most of the people would not have the pre-op data. Yeah. The other thing probably I would like to mention is there is something like a back of the thumb rule if you're dealing with RK patients. So you just add about 3 to 4 diopters and then you will be fairly close, maybe a little bit myopic, and that is, if you do not have excess, that is something what you can do.
True. Actually, RK scars we can see, but post-LASIK patients, the ones who are coming in now, and sometimes they don't want to tell in front of the, because they've not even revealed after marriage that we have had this procedure then. So I always have a good look at the K reading, and if the K is flatter than you would expect in a normal person, because the LASIK scar is sometimes you can't see it on the slit lamp. So we just have to take a good history from the patient.
Yeah, I had a patient where the right eye was amblyopic, high myope, and the left eye had both eyes had a cataract, but when we did the A scan, patient did not mention it. So one eye had a keratometry about 45, 46, the other eye had about 36, 37. So that raised a red flag that obviously then we asked, and then we got to know that he had a PRK only in one eye, only in the left eye. So yeah, you have to keep a watch on that.
The other giveaway is, for example, I have a NIDAC AL scan. It gives you the central pachymetry also. So you can just take a look at it. If it's something like 400 something or 300 something, yeah, you have to really get after the patient. Yeah. So I think after all the theoretical discussions, we have our man of action, Dr. Ashish Lall.